Delayed gastric emptying. विषय में it is the commonest complication of pancreaticoduodenectomy. And unlike hemorrhage or fistula, it is rarely dangerous. Its cost is measured in nasogastric tubes, delayed feeding, and hospital days, not in mortality. Over the next 15 minutes, I will set out a contemporary evidence based approach organized around one clarifying idea that delayed gastric emptying is really two different entities wearing a single name. First, the burden. Before a common definition existed, reported incidence ranged absurdly 19 to 57% because every center measured differently. Applied uniformly, clinically relevant grade B or C disease settles around 5 to 20%. All grade figures reach 30 to 45% in complicated cohorts. Its importance is not lethality, it is prolonged recovery. A stay longer by some 5 to 6 days, significant added cost, a leading cause of readmission, and, in malignancy, delay to adjuvant therapy. The central idea is this: delayed gastric emptying is not a single entity. In roughly 70% of clinically relevant cases, it is secondary. Gastric stasis provoked by an intra-abdominal complication, a pancreatic fistula, an abscess, or a collection. In the remainder, it is primary, an idiopathic disorder of gastric motility, milder and shorter. That distinction is not academic, it determines the entire treatment. Secondary disease is cured by treating its trigger. Primary is managed supportively while it resolves. These are codified in the ISGPS consensus definition of 2007, which grades delayed gastric emptying on the duration of mesogastric intubation and the day solid food is tolerated, once a mechanical cause has been excluded. Grade A: a tube for 4 to 7 days, solids by day 7, a transient nuisance. Grade B: a tube to 2 weeks, solids by day 14, prolongs the stay, needs support. Grade C: a tube beyond 2 weeks, solids by day 21, a major change in management. The grades are prognostic, they track resource use and discharge. Return to the distinction because it is the practical heart of the topic. In a two-center series of over 1100 pancreaticoduodenectomies, 16% developed delayed gastric emptying and 72% of it was secondary, needing longer nutritional support and hospitalization. In a stomach-preserving series, pancreatic leakage was the sole independent risk factor for clinically relevant disease. Odds ratio 6.6. The lesson: when the stomach will not empty, look first for what is happening around it. The mechanism is multifactorial and for primary disease still partly hypothetical. Resection of the duodenum removes motilin producing cells and the duodenal pacemaker and disrupts gastroduodenal neural continuity, producing gastric atony and dysrhythmia. Devascularization and denervation of the antropyloric mechanism may add pylorospasm. For secondary disease, the mechanism is simpler and better evidenced. An adjacent inflammatory focus, a fistula or abscess, provokes gastric dysrhythmia and stasis. Risk stratification is dominated by the postoperative complications that drive secondary disease. In a meta-analysis of over 9,000 patients, the strongest associations were intra-abdominal collection, odds ratio 3.6, abscess 3.1, and pancreatic fistula 2.1. The corollary is striking. Where fistula and infection are excluded, incidence falls from about 31% to under 12%, and the risk profile becomes weaker and patient-related. Age, male sex, chronic lung disease. Prevent the complication and you prevent most of the stasis. Diagnosis is therefore a diagnosis of exclusion, and the sequence matters. VAR, the ISGPS, is explicit. confirm patency of the gastro or duodenojejunectomy by endoscopy or a water-soluble contrast study. A demonstrable stricture or obstruction is a mechanical problem, not delayed gastric emptying, and must not be graded as such. Then image the abdomen with CT for the collection or fistula behind secondary disease. Scintigraphy can confirm stasis but is rarely needed. Exclude a mechanical obstruction and a collection before you settle on delayed gastric emptying. Here is the whole approach on one slide. Grade by ISGPS, weigh, then exclude a treatable cause, CT for a collection or fistula, a contrast study for mechanical obstruction. If it is secondary, treat the trigger. If it is mechanical, dilate the stricture. If it is primary, support the patient while the stomach recovers. Every decision flows from that one branch point. A great deal of randomized effort has gone into preventing delayed gastric emptying by altering the reconstruction, and the honest summary is sobering. At the level of randomized trials, no single technical maneuver reliably prevents clinically relevant delayed gastric emptying. Signals that look convincing in observational data have repeatedly evaporated when tested in randomized trials. The confounding in retrospective series is severe. That is the teaching point. It turns attention away from reconstruction tinkering towards preventing the fistula and collection that cause most severe disease. Take the individual questions. Anticolic versus retrocolic routing of the gastroenteric anastomosis. An early single-center trial found a dramatic advantage for the anticolic route. But the larger multi-center trials and the Cochrane meta-analysis of 8 randomized trials show no significant difference. Odds ratio 0.67, the interval crossing 1. Choose the route on other grounds. It does not prevent delayed gastric emptying. Pylorus resection versus preservation. Observational data and an early trial suggested that resecting the pylorus reduced stasis. The question was then settled by the blinded PROP randomized trial. Delayed gastric emptying was 31% with resection versus 25% with preservation. Odds ratio 1.5, not significant, and if anything, numerically worse. The randomized subgroup of the meta-analysis agrees. Preserving or resecting the pylorus makes no reliable difference. The same pattern repeats for the Braun enteroenterostomy. Favorable in pooled observational data, but every randomized trial is negative for overall delayed gastric emptying, reaching significance only and inconsistently for the most severe grades. And loop configuration makes no difference. The PODA trial of Billroth 2 versus Roux-en-Y found delayed gastric emptying in 45% of each arm, identical. Configuration is not the lever. And minimally invasive versus open surgery? In randomized trial-only meta-analysis, the relative risk sits right on 1. No significant effect on delayed gastric emptying. Observational network analysis favored the minimally invasive approach, but that is lower certainty confounded evidence. A robotic or laparoscopic approach may be chosen for other reasons. It is not an established prevention strategy for stasis. Is there a pharmacological lever? The classic answer is erythromycin, a motilin receptor agonist. In Yo's placebo-controlled trial, erythromycin from post-operative day 3 produced a 37% relative reduction in delayed gastric emptying. Two caveats for this audience. First, that is essentially prophylaxis. The drug was started early before stasis was established. Second, a modern meta-analysis finds the effect no longer statistically significant on a small, imprecise evidence base. Reasonable to use prophylactically, do not expect it to rescue established disease. The intervention with the most consistent signal is the enhanced recovery pathway. Early oral and enteral feeding and avoidance of routine nasogastric decompression. In an individual patient data meta-analysis, It reduced all grade delayed gastric emptying and shortened length of stay. Though, honestly, it did not significantly reduce the clinically relevant grade B and C disease. It makes the mild cases milder and gets patients home sooner. 2. Management, which follows directly from the branch point. For secondary delayed gastric emptying, the treatment is treatment of the trigger. Drain the collection percutaneously or endoscopically, control the fistula and the sepsis. As the inflammatory focus is controlled, the gastric stasis resolves. You are not treating the stomach, you are treating what surrounds it. For primary delayed gastric emptying, management is supportive while the stomach recovers. Nasogastric decompression, correction of fluids and electrolytes, and nutrition through what can be a prolonged course. On the route of nutrition, the evidence is clear. Time to normal oral intake was similar with nasojejunal feeding, surgical jejunostomy, or parenteral nutrition. But parenteral nutrition caused more wound infections, and surgical jejunostomy caused catastrophic complications, including a death from bowel strangulation. So the nasojejunal tube is the conduit of choice, and routine prophylactic surgical jejunostomy is to be avoided. And prokinetics for established disease? Here the field is honest about its limits. Hell, a systematic review of 152 randomized trials concluded that no trial has identified an effective treatment for established grade B or C disease. Metoclopramide and domperidone are used empirically by analogy with idiopathic gastroparesis without post-pancreatectomy trial support. Botulinum toxin and gastric electrical stimulation are unproven in this setting. Hell, the evidence supports prevention and support, not a curative drug. The impact on outcome is on recovery, not survival. A delayed gastric emptying prolongs the stay by some 5 to 6 days, adds materially to cost around 10,000 euros or dollars for an isolated severe case, and is a leading cause of readmission. But across these large series, it is a low burden complication that does not itself drive mortality. The lethal complications after this operation are hemorrhage and fistula. Gastric stasis is a burden on recovery, not on life. A necessary appraisal. The ISGPS definition standardized reporting, but it grades severity without regard to cause, lumping a trivial grade A with a fistula-driven grade C, which is why headline incidence swings from 14 to 45% depending on how completely the trivial cases are captured. The primary-secondary distinction, though well validated, is not part of the formal definition. The prevention literature is a cautionary tale in confounding. Observational series favoring maneuver after maneuver that randomized trials then found null. And there is a genuine evidence vacuum exactly where the need is greatest. No proven treatment for established severe disease. In summary of evidential strength, the definition and grading are validated consensus. The negative verdict on reconstruction techniques rests on level 1A randomized meta-analyses, the preference for nasojejunal feeding on level 2 cohort data, and the enhanced recovery benefit on level 1A to 2A evidence. The recommendations here are unusually as much about what not to do as what to do. In synthesis, 6 principles. 1. It is 2 entities, separate primary from secondary. 2. Diagnose by exclusion, confirm anastomotic patency and image for a collection. 3. In secondary disease, treat the trigger. 4. No reconstruction technique reliably prevents it. Choose on other grounds. 5. For primary disease, support the patient. Feed nasojejunally. Consider erythromycin. Expect resolution with time. And 6. The highest yield prevention is preventing the fistula and the collection. That is, delayed gastric emptying after pancreaticoduodenectomy, from the literature to the bedside. Thank you for your attention.